Thank you, Dave. Hello again. Before I start my talk, I just wanted to give an opinion about the app. I think it's an excellent endeavor, and especially for patients that are on a lot of different medications. For instance, lenalidomide, Ninlaro, dexamethasone. A calendar is always good, but not always a good calendar is made. So I think that the app may help a lot of patients. Sometimes my nurse actually brings in little labels, colorful dots to put which day is what. So if that can be put in the app, that's going to be a great resource to help our patients not to get confused with what medication they're going to get. So Dave, thank you so much for your testimonial about your blood clot. It is true, I do wear two hats, and to be honest with you, I've given a number lectures on thrombosis and cancer, which is one of my main areas of interest in research. But this is the very first time that I'm officially going to talk about thrombosis and myeloma, which is an area, like it's an orphan area in cancer research and education. So I'm very, very pleased to have this opportunity here today. So we are going to review, let me see if I'm doing the right thing. Oh. I didn't undo it, I'm sorry. Just Gabe. Okay, here we go. So again, disclosures are the same. And after, at the end of the session, I would like you to be able to identify the difference between arterial and venous clots, be familiar with the most common signs and symptoms of both clots, of blood clots, both in the arterial and the venous areas, and also be familiarized with the most common blood thinners that are available in the market. So first question to be asked is, what is a thrombosis? So thrombosis has actually several names. Technically, we call it venous thromboembolism, or VTE, for venous clots. Or for arterial clots, there are several different names. One very general name is cardiovascular event. But in commonality, we just simply say blood clots. And blood clots is a very general name, can be used for arterial or for venous clots. So where do they form? So they can form in the arteries and they can form in the veins. So here in this cartoon here, the arteries are the red vessels and they are rich in oxygen. So they go from the lungs to the heart, from the heart to the whole body to provide oxygen to all of our cells. In counterpart, we have in blue the veins. So you see that they basically follow the pathway, but one, let's say, is going from the heart down and up, and the other one is going from the peripheral areas in our body back to the heart in blue with the oxygen poor blood. So that oxygen goes from the peripheral areas of our body back to the heart, then to the lungs, where it's going to be freshened up, receive oxygen, and then we go from there. So it's a cycle, a non-stop cycle, so that we can be healthy. So whenever we have clogging in our arteries, we are going to have problems. And one of the major ones would be a heart attack or a stroke that happen in our brain. If we're having clogging of our veins, we're going to have what we call deep venous thrombosis or pulmonary embolism when the clot happens in the lung vessels, like you can see here in this picture. David, for instance, had a blood clot in a very small vein in the back of his eye. That's actually called an unusual site thrombosis, because in the majority of time when there is a venous thromboembolism, it happens in the legs, the lungs, or the arms. So larger vessels, not so much the teeny tiny ones. So a little bit of background around thrombosis and cancer. So thrombosis is actually one of the major complications of cancer. In solid tumors, it's actually the second leading cause of mortality, just followed by death from cancer itself. So this, I'm talking about solid tumors, so breast cancer, lung cancer, cancer of the brain, colon cancer, and so on and so forth. When we compare the incidence of thrombosis between the general population and and the patient with cancer, you can see here that patients with cancer have a 5-fold higher risk of thrombosis compared to the non-cancer population. Also, when you have active cancer, the incidence of thrombosis usually occurs within the first 6 months of the cancer diagnosis. And this is intuitively reasonable because when you are diagnosed with cancer, that's when you have the most cancer burden. That's when you're going to go for surgical procedures. That's when you're going to need catheters put in you so that you receive chemotherapy. And that's when you start your chemotherapy or radiation therapy that are also agents that increase the risk of blood clot formation. So the risk is much higher during the first 6 months of cancer diagnosis compared to subsequent periods. The association with thrombosis in cancer denotes poor prognosis in solid tumors. So the mortality for patients with solid tumors at 1 year is 3-fold higher in patients with cancer and thrombosis compared to patients with the same cancer that do not have thrombosis. So for instance, a patient with lung cancer that develops a blood clot has a 3-fold higher risk of dying within a year compared to a patient with the same type of lung cancer that did not develop a blood clot, okay? So this is true for solid tumors. This is not the same for myeloma. So thrombosis in solid tumors is associated to mortality because the blood clot in the solid tumor is formed to shield the cancer cells. So the cancer cells are smart, so what they do is that they hide behind the blood clot so that they can go to distant areas and form what we call the distant metastases. And this way they can proliferate in foreign areas in the body and they can continue to grow. So this is a way that they hide from the patient's immune system because otherwise the immune system would see that cell as a bad guy and would attack that cell. In multiple myeloma, this is not the case because multiple myeloma is a disease that is everywhere already because our blood is everywhere, right? So we don't have such as metastases. It doesn't happen in multiple myeloma and the other hematological cancers. So in myeloma, there's another driver for thrombosis formation. So what would that driver be? So basically, what we see in multiple myeloma is that multiple myeloma is a disease that is driven by inflammation. So what is inflammation that I put in green there for you? So just think of your sore knee or your sore hip. They're sore because there is inflammation in there. So many people that have problems in their joints, they feel not only pain, but they feel stiffness. Stiffness is a result of swelling. Sometimes there's redness around that joint as well. Sometimes there will be discoloration even or some warmth in the area. So this is all a result of inflammation. And inflammation is developed by some chemicals that are released by our immune system cells. And myeloma, being an immune system cell, produces or stimulates production of those chemicals so that it may survive in the marrow microenvironment that Dr. Chain was talking about to us in the morning. So one of the ways of the myeloma cell to be kept alive in the bone marrow or even outside the bone marrow is by stimulating production of inflammatory substances that will enable its survival wherever it is. But inflammation is like candy for the proteins that form blood clots. So if you have a lot of inflammation, you're naturally going to be more predisposed to developing blood clots. On top of this, myeloma is a disease of the elderly, and as we get older, our risk for developing blood clots also naturally goes up. So if you compare a person that's 25 years old with a person that's 80 years old, the risk of blood clotting in the 81-year-old person is 80-fold higher than the one that's 25. So it is naturally a higher risk for all of us that are aging to have blood clots in the future compared to younger people. In addition, as we also get older, we have other conditions, chronic conditions, such as high blood pressure, high cholesterol, diabetes, or we smoke, or we lead a sedentary life. All of those will also predispose to blood clot formation, especially arterial blood clots. And mobility, that many times is an issue in the myeloma patient because of bony pain, because of tiredness, because of infections. Patients don't mobilize very often. And it's easy to think, like when you go on a long trip, especially when you go on a long trip by plane, you always see that your legs and feet get swollen, right? So it's this, our feet are always swollen and stiff after a long trip, right? So this is because there's not enough blood flow because we've been sitting down for hours. So this predisposes to blood clot formation as well. And last but not least, myeloma drugs. Myeloma drugs can also lead to blood clot formation. And the most important drugs in that field are lenalidomide, pomalidomide, thalidomide, and carfilzomib. So those drugs usually require that you use some preventive anti-clotting medication to avoid an increase in the risk of blood clots for you. So myeloma patients are predisposed to both arterial and venous thrombosis, whereas patients with solid tumors are more predisposed to venous clots. Good news, I don't really know if it is good news, but like solid tumor patients, myeloma patients carry a higher risk of venous clots compared to arterial clots. This is the result of a small chart review that we conducted in my center, London Health Sciences Center, together with our colleagues from Salamanca in Spain. So we evaluated the charts of 168 myeloma patients that were on lenalidomide and dexamethasone. All of the patients were on some sort of blood thinner to prevent blood clot formation. And even though they were on preventive medication, 9.5% of patients still developed a venous thrombosis, and very few developed an arterial thrombosis. So that tells me that even though myeloma patients are also at risk of arterial clots, they are more predisposed to venous clots, and the preventive medications we're currently giving is not enough, because any risk of blood clot that's higher than 5% in the context of cancer is considered high. So here we're seeing 10% basically, so that's double than we can consider normal in quotation marks. And this mirrors other studies in the literature. So it's all about balance, right? So we have our natural clotting system and our anti-clotting system. They live in harmony in our bloodstream, in our vessels. Whenever there is an imbalance, if there is an imbalance towards the clotting system, we're going to have predisposition to developing thrombosis. If there is more weight in the anti-clotting system, then you're going to have a predisposition to bleeding complications. So we always have to have the balance between the two. So this cartoon here looks really beautiful and really, really busy, but this is to show you in a very simple way, actually, that whenever there is a vessel wall injury, so this is a vessel, this is the blood flow, and these are several proteins and cells that are floating in our blood. So here you see that there was a rupture in the vessel wall. And whenever there's a rupture in the vessel wall, it doesn't matter if you cut yourself with a knife or if you were running to the bus stop and then you ruptured a bunch of small little vessels, teeny tiny vessels in your feet, or if you had a surgery. If there is a section, if there is a rupture of a vessel, that vessel needs to be repaired. And our blood clotting system is very efficient in repairing any injuries that we promote to our vessels, whether those are voluntary or involuntary. So how does that work? So once you have the ruptured tissue here, this ruptured tissue will trigger signals to your blood clotting proteins that you're going to see here highlighted in yellow, and they will start to become active, and one activates the other, so they go into a cascade that will culminate in the blood clot formation up here. At the same time, the proteins in blue are the natural anti-clotting system, and they will also be triggered and activated so that they can halt the function of our clotting proteins. Otherwise, we're clotting forever. So they're very important to stop the blood clotting process once the clot is formed and fixes the problem. So in the cancer setting, the problem is that even though you do have these proteins around, these here are more active because there are more substances on top of them, making them continue and bypass the signaling pathways of these anti-clotting proteins here. So again, it's all a matter of balance. So how do we recognize if we are developing a blood clot or not? What are the most common signs and symptoms of thrombosis? So in venous thrombosis, as I was telling you, the most common types of thrombosis are what we call deep venous thrombosis that happen mostly in the arms and the legs. So usually it comes up as swelling of your legs and feet, usually one leg only, redness in the same leg, tenderness in the calf, behind the knee, also tenderness present in the inner aspect of your thigh or in the groin. If you have a blood clot in the arm, then you're also going to have swelling of the arm, swelling of the affected hand, and pain also all along, sometimes even pain in the neck. Redness in the arm can also occur, and this gets progressively worse with the passing of days. Blood clots in the arms are most common when you have a PICC line or a perm cath inserted, or if you have, for instance, a tumor that's pressing on the vessel, and then you will develop, that will promote the blood clot formation. Those are the most common ones, but sometimes we do see patients with spontaneous clots in the arms as well. For the lungs, okay, doesn't like me? Here we go. So for the lungs, we call pulmonary embolism the blood clot in the lungs. The blood clot in the lungs can happen only in there, but in 80% of cases, the blood clot that's happening in the lungs actually came from the legs. So it's always important to assess your legs with an ultrasound to see if there are blood clots in there when you have confirmation of blood clots in your lungs. So PE, as we call it in short, for pulmonary embolism, the symptoms are acute onset of shortness of breath or chest pain, especially when you take a deep breath. It hurts. This starts, let's say, in the morning, and it quickly gets progressively worse with the passing of hours to days. You may also have cough, fever, chills. Sometimes the cough can be accompanied by throwing up blood. You usually also feel that your heart is racing, and because your lungs are clogged, there's no good oxygenation going around your body, so you may actually feel lightheaded and sometimes even faint. So this is a very dangerous disease, and it should be diagnosed and treated as quick as possible. For the arterial thrombosis, there are a number of different complications that can occur in your cardiovascular system. I will give you an example here of two common ones for the general public. So heart attack and ischemic stroke. So heart attack is when you have clogging of the arteries that feed your heart muscle. So if you have a blood clot clogging these arteries, your heart muscle is actually the tissues are actually going to die. That causes pain, and that also prevents your heart from pumping blood appropriately. So then what's going to happen is you're going to have chest pain. The chest pain usually lasts more than 20 minutes. It may radiate to the jaw or to your arms. It may also look like you have a bad heartburn that doesn't go away. You may have cold sweats. You may have difficulty breathing, and you also may feel faint. So these are the most common signs and symptoms of a heart attack. And for stroke, we have this mnemonic here called FAST. So you see facial droop. The face looks uneven, especially your lips. One of the arms is usually weaker, so it's hanging. The person is not able to lift it up normally. and you see slurred speech. So whenever you see that happening, is to call 911 immediately. If you call 911, or if you go to somebody takes you to the hospital right away, chances are that you will be diagnosed on a timely fashion, you will start treatment promptly, and then you'll be okay. If it lasts too long, sometimes this delivers complications, even death. So we really have to be careful. Obviously, for instance, if we're talking about a pulmonary embolism, but you know you have a pneumonia and you're having chest pain and shortness of breath and fever, you don't think you have a pulmonary embolism because you know you have a pneumonia, right? So you have to try to and learn to differentiate the symptoms. But if you don't know how to do that and you're worried, go to the hospital. Don't wait. Never underestimate your symptoms. You might as well always play on the safe side. So how are blood clots treated? So let's say one of us here is diagnosed with a blood clot. How are we treated? There's a myriad of anti-clotting proteins that are available for different conditions. But roughly speaking, these here are the popular ones, are the most widely used. And of course, baby aspirin, for many, is not even considered a medication, but in fact it is, and it does cause side effects, so we need to know how to use it. Another very popular one is rat poison, warfarin, that many of you know. Warfarin has been around for over 100 years. It is a wonderful drug for prevention of blood clots, somewhat difficult to monitor, but in thrombosis clinics we are specialized, and we can do that in a very easy and safe manner for you. Warfarin was the only oral anticoagulant that was available in around until early 2000s, like let's say 2010, when other oral anticoagulants came out that are the DOACs. But before talking about the DOACs, I'll talk to you about the heparins. So heparins are injectable anticoagulants. The mother of heparins, which is called unfractionated heparin, has also been around for over 100 years. But these guys here are subcutaneous injections, so injections under the skin that you take on a daily basis. They've been around since the early 2000s. And here we have the DOACs, direct oral anticoagulants. They are our new kids on the block. We have 4 of them available in the market for different indications, and all of them are approved for treatment of venous thromboembolism and certain arterial blood clots. So which one of them is the best? We have so many. How do we choose? And me, as a thrombosis physician, how do I pick the best blood thinner for my patient with cancer and thrombosis, and specifically my patient with myeloma and thrombosis? So let's take a look at how they work and what they are. So aspirin is very good for prevention and treatment of arterial blood clots, not so good for treatment of venous clots, but can be used for prevention. It is convenient because it's oral, it's a pill, and it has a fixed daily dose. Warfarin is good for arterial, good for venous clots, so good for both. It is a pill too, so very convenient, but it does have the inconvenience of the need for laboratory monitoring. So you have to go to the lab with a relatively frequently, because you need to see if your blood is too thin or your blood is too thick. Heparins are great drugs for both arterial and venous clots, but they're inconvenient because they're daily injections, but they are fixed doses and they are cleared by the kidney. So patients with significant kidney compromise may not be eligible to receive those drugs. And apixaban, rivaroxaban, and edoxaban are DOACs. They're all good for certain arterial clots, but not all of them. They're universally appropriate for venous clot treatment. They are pills. They do not need lab monitoring. They are at fixed doses, and all of them have some degree of what we call renal clearance, so they are excreted by the kidney. So again, if you have a significant renal compromise, those drugs, those medications may not be the best suited for you. And this is the case many times with multiple myeloma, so we need to look at those drugs with care when we're considering treatment for myeloma patients with thrombosis. So here we have the summary of the major clinical trials done in venous thromboembolism, so venous clots, not arterial ones. Those studies were actually designed to assess general population patients that develop blood clots. So more than 30,000 patients were evaluated in these clinical trials. And there was a small proportion of them, roughly close to 2,000 patients, that actually had active cancer. So this is the pooled analysis of those patients with active cancer. And they were compared the use of direct or anticoagulant versus warfarin with respect to risk of recurrence of their venous clots. And if we look at the numbers here, we see that the use of the DOAC is pretty similar or actually better when compared to warfarin. So patients actually reclot less on the DOAC when we compare the patients that use warfarin. This looked quite appealing, but at the same time it's dangerous because these studies were not designed to assess the efficacy and the safety of those drugs in cancer patients, but it looked quite promising. When we looked at the major side effect of blood thinners, which is bleeding, we also see that the profile is quite impressive. DOACs actually are better than warfarin in preventing major bleeding. So major bleeding is that bleeding that requires medical intervention. So once again, very appealing, but not appropriate. So around 2014, 2015, we were not prescribing those newer drugs to our thrombosis and cancer patients. But with these data, specific studies in the cancer population were developed and conducted. And here you have the result of the 3 major studies. Together, they encompass roughly 1,600 patients, and all of the studies compared a DOAC with a heparin called dalteparin. And when we look at the numbers, we see that major bleeding is usually slightly worse in the DOAC arm compared to the dalteparin in those 2 studies here, not really here, but we have to see that the numbers here are quite small. And the clot recurrence or thrombosis recurrence is pretty similar across the study arms, so pretty similar between these 2. Similar here as well. I mean, better here on apixaban, actually numerically better. And here it's better in rivaroxaban compared to heparin as well. So based on these trials, the medical community has felt more confident in prescribing these newer drugs to our cancer patients. But I have to state that it depends on the type of cancer. And if you ask me how many myeloma patients were in these trials, very few, because myeloma is a rarer cancer. So even though we know there are a lot of patients with myeloma, they are only 1% of all cancers. So in general, in clinical trials, 90% of patients will have solid tumors, 10% hematological cancers, and of those, majority will be lymphomas, leukemias, and a small proportion myeloma patients. Myeloma patients are many times excluded from clinical trials because of their renal impairment, their kidney dysfunction. So how long is treatment with blood thinners necessary? So how long am I going to be on blood thinners if I have a blood clot? Majority of myeloma cases, 10 minutes. Majority of myeloma cases, lifelong, because our current guidelines state that if there is an active cancer on or cancer treatment is ongoing, your patient with cancer and thrombosis needs to be kept on treatment with blood thinners. So ideally in myeloma, that's a chronic disease, lifelong. Exceptions to this rule, if you have a blood clot associated to your PICC line or your perm cath, that's usually a shorter period of time of about 3 months only, or obviously if you have significant side effects. And as I told you, the really one and only side effect of blood thinners is bleeding. So if you have a significant bleeding complication, then you probably need to hold or stop your anticoagulants for good. But how about prevention? So can I avoid to develop a blood clot since I have a cancer or since I have multiple myeloma? Well, you can always try, right? So for arterial thrombosis, no clinical guidelines have a firm recommendation or suggestion with respect to prevention of arterial clots. For venous clots, the International Myeloma Working Group suggests that patients that are on the IMiD drugs, pomalidomide, thalidomide, or lenalidomide, use either baby aspirin, one of the heparins, or warfarin therapy. What do we know about prevention of blood clots in patients with cancer? So here we have the results of the AVERT trial that looked into apixaban low dose versus placebo in patients with cancer. So when you look here at this graph, you see that the use of apixaban significantly decreased the risk of thrombosis compared to the placebo group. So this is a 2 thumbs up. Similar results, but not so robust in the Cassini trial that looked into the other DOAC, rivaroxaban, also at low dose, 6% of patients versus 8.8% of patients that were on placebo. So showing a beneficial trend with the use of rivaroxaban for those patients with cancer. But what about myeloma? Do we have any evidence for prevention of blood clots in myeloma? We do, but very little. It's minimal. So here we have 2 studies that were performed. So both of these studies looked into apixaban, low dose for patients with myeloma using either lenalidomide or thalidomide-based therapy. We have small number of patients, but very interesting results, very hopeful results, because we see here a very small number of arterial clots or venous clots happening while patients are on apixaban, and also a minimal rate of major bleeding. So this is quite appealing. We have also now I'll broadcast a little bit, because we now have the RHYTHM pilot trial. RHYTHM stands for rivaroxaban, thrombosis, and multiple myeloma. This is an all-Canadian study. This is a phase 2 or pilot trial. The participating centers are London, Ottawa, Winnipeg, and Hamilton. The London site is the only one that's currently open. We opened about 3 months ago. The other 3 centers are working with their research ethics board to get all the paperwork and contracts in the works so that they can start enrolling patients. In this study, we intend to enroll 86 patients with active myeloma on lenalidomide-based therapy to test the safety, meaning bleeding risk, and efficacy, meaning prevention of thrombosis, with the use of aspirin, comparing it to rivaroxaban. So there has never been a clinical trial comparing aspirin to a DOAC in myeloma. So this is going to be the very first one in the world to see how effective those 2 drugs are in preventing blood clots. Once we show that there is some answer with this intervention, we will then move up to the full RHYTHM trial, where we will intend to enroll roughly around 400 patients, and for that we will need many more Canadian centers. So the hopes is that this will be one of our MCRN trials, and we anticipate the need to about 10 centers so that we can enroll around 400 myeloma patients. So that, stay tuned, because that is about to come. And hopefully this will give us some light in the end of the tunnel to this unanswered burning question of what to do with myeloma patients on lenalidomide, pomalidomide, thalidomide that have an increased risk of blood clots. And right now, 89% receive baby aspirin, and there's still failure, significant failure of baby aspirin in preventing blood clots to our patients. And that's it for now. Thank you so much.
Okay, a most educational presentation. We do have time for maybe a couple of questions. I think there's one over here. If Sophia, if you could take the mic, please.
Hi, Sophia.
Hi. In that two study with the 82 patient, did you have a control group?
No.
Okay, I wanted to know the percentage, yes.
Exactly.
Those who didn't get this kind of treatment, what was the control group? So
There was no control, so that's what
Okay.
I'm saying. We actually have another couple of studies that were done. So all the studies on apixaban and a couple of studies on rivaroxaban, they're either retrospective, just case series, or they are prospective cohort studies. So there's no arm, there's no comparator.
Okay.
So our study, the Rhythm trial, is the only one that has a comparator, and we are comparing to the current standard of care, that's aspirin. So I think this is going to shed a lot of light in the end once the study is accomplished.
Thank you.
I was wondering if there is an antidote for the DOACs. Yeah.
Oh, I saw you. Yes, that's an excellent question. There is an antidote. However, the antidote is not approved yet. So it is in the works of being Health Canada approved. It is not funded. It's called Andexanet. So all of these DOACs, except to the bigatran, they do block one clotting protein that's called factor 10A. So Andexanet is actually a mimic of factor 10A, but it doesn't have the clotting proteins. So basically what that drug does, it competes with the actual factor 10 to the rivaroxaban, let's say, binding site. So it is a very potent drug. It is not only going to be the antidote for rivaroxaban and apixaban and edoxaban, but also of the heparins, because the heparins also target factor 10. The bigatran has an antidote. It is already approved. It is in the market. It is used for patients with bleeding. But we usually don't use the bigatran because it's a drug that causes a lot of heartburn. So patients majority of times hate it. We use more one of the other ones. Yeah, yeah.
Over here.
Hello? Oh, sorry.
Yeah.
Oops, go first.
Okay, over there by Michelle, please.
Okay. Hi, I've had about 5 cases of blood clots in different parts of my body, and it's more of a comment, but with base. Oh, there we go. Just for patients, when you are getting the ultrasound, what happened was the blood, because I had a PICC line in my arm, and my arm was swollen and painful and all of that. When the technician who was conducting the ultrasound went up and down my arm, and she said, well, no, you don't have a blood clot. And because even my oncologist trusts me when I say I have a blood clot. So I said, no, I'm sure I have a blood clot. So I asked her, can you just please adjust slightly where she was running that, whatever it's called, up and down your arm, the wand. And sure enough, actually it was his eyes popped out and said, well, you've got a blood clot from shoulder down to your wrist. So just for patients here, there's patient advocacy here. Don't be shy if you think they've missed it. They don't feel what you feel inside your arm. Do you have more comment on that?
Well, sometimes it's difficult to see the blood clot for a couple of reasons. One of them you mentioned, the swelling. The other one is the pain. So sometimes the technician cannot put enough depth of the probe because the patient is in pain. And when there is swelling, ultrasound, if you look at an ultrasound, even if you look at an ultrasound of a baby inside the mommy's womb, you cannot really devise what is what, right? Because it's all very blurry, and it really got to have the eye to see that a blood clot is in there. So it is okay what you did. It is totally okay. And it's good that this technician took it in a good way and actually, changed, because they can change the way. It's like you have TV, you have the brightness. So you can put it brighter or you can put it darker, and then you can see one tissue better than the other. So it's really a fine tuning many times. It's different from when you do a CT scan and you really look at the blood clot that's in your lungs, right? It's easier when you do that, or it's easier when you do a catheter of your heart and you eyeball the clogged artery. The ultrasound is more of an expertise, an experience type of procedure. And even though it's not an invasive test, because it's a probe that they really, squeeze into your skin, it can be uncomfortable.
Time for one last question. Leslie?
What do you say to somebody is taking a baby aspirin, being on Revlimid or whatever, and suddenly their platelets drop down to 60? You stop the aspirin?
No,
it's a
we're
different-
usually comfortable with platelets up to 30.
Continue with the aspirin.
Yeah. So platelets up to 30, I would say safe with the heparins, safe with the DOACs, not so much. So what I would say is if you are in one of the DOACs or if you're on aspirin, ideally platelets above 50 and platelets of 30 with the low molecular weight heparins should be fine. Yeah.
Okay, well, again, we are so fortunate to have Dr. Louzada here, not only a very knowledgeable myeloma doctor, but also knowledgeable in thrombosis. It's an area that really is important for myeloma patients. So thank you for giving us that presentation, and also the RITH-MM trial. I believe you initiated that,
Yeah.
Dr. Louzada, and you are the leader, the principal investigator for the pilot trial at the 4 sites, and hopefully sometime to be a nationwide MCRN trial. So thank you so much for that.
Thank you for this opportunity.